Myeloma is a hematologic malignancy where we had the highest number of approved drugs indication by EMA and FDA. So it was the right time to update guidelines so that we align our treatment recommendations with the approved therapies.
With 14 novel regimens now recently approved for multiple myeloma, how did the guideline panel approach integrating these new therapies with established standards of care?
As you understand, it was a very difficult process. So what we did is that we try to have a subgroup of patients in order to make it more easy for the treating physicians to follow these guidelines.
Welcome to EHA Unplugged, the official podcast channel from the European Hematology Association, EHA. I am Professor Pieter Sonneveld from the Department of Hematology at the Erasmus Medical Center Cancer Institute in Rotterdam, the Netherlands. Today I'm joined by Professor Meletios Dimopoulos and Professor Evangelos Terpos, together with a group of experts from EHA and EMN, the European Myeloma Network. We have recently published a complete set of updated guidelines for patients with multiple myeloma. Welcome, Professor Dimopoulos. Can you please introduce yourself?
I am a professor of hematology and oncology at the School of Medicine at the National Kapodistrian University of Athens, Greece.
And welcome, Professor Terpos. Can you please also introduce yourself?
Evangelos Terpos, professor of hematology in the National Kapodistrian University of Athens in Greece, and also a member of the board of the European Hematology Association.
So we are here together to help you navigate the recommendations of the guidelines panel. And I would like to start with the guidelines incorporate new prognostic factors such as minimal residual disease, MRD, circulating plasma cells, and mass spectrometry for monoclonal protein. How do these tools improve the risk stratification and patient management? Professor Terpos.
I think what we managed to do in these guidelines is not only to describe the new methods that we believe that in the near future will be standard of care for myeloma management, but also to show what is their prognostic value and also their value in the management of multiple myeloma. If we start from the minimal residual disease, although the myeloma community had recognized since 2016 that MRD is an important prognostic factor, and that's why it has been incorporated in the response criteria of the International Myeloma Society and the International Myeloma Working Group. However, we haven't used it a lot in our clinical practice, especially for treatment decisions. We know very well that MRD negativity is a very good prognostic marker because it correlates very well with the PFS and the overall survival. However, to date, there are not so many data suggesting that the MRD negativity can drive decisions. The EMN study, the European Myeloma Network Perseus study, is one of the studies that uses MRD in order to define if in the maintenance setting, for example, we can avoid some of the drugs that are used. So I think that MRD is an important prognostic marker, but possibly in the near future is going to be incorporated in treatment decisions. Another important issue about the MRD is that the FDA has recognized MRD as an endpoint for clinical trials. So in many clinical trials, it is a co-primary endpoint with PFS in order to have results more quickly than the PFS that, as you understand now in myeloma, it may need, especially in the first line, more than 7-10 years for the read. Circulating tumor cells. This is another important prognostic marker. We know that it has prognostic value in both symptomatic but also asymptomatic multiple myeloma in patients with newly diagnosed or relapsed refractory multiple myeloma, and it seems that it can be incorporated with other markers in the near future. The combination of MRD plus circulating tumor cells that both have independent prognostic value may give a better prognostic impact for our patients. Finally, mass spectrometry offers us the possibility to detect very low amounts of M protein that cannot be detected with the standard electrophoresis and immunofixation that we use in our clinical practice. Although mass spectrometry is not widely available all over the world, we described the technique in the new guidelines because we all believe that the mass spectrometry is going to be used a lot in the near future for the detection of these small proteins in diseases like amyloidosis, but also in myeloma for the response of the disease.
So these are new tools for the clinician to make let's say, an estimate of the prognosis of patients, but not yet part of routine clinical practice. So the guidelines, they offer a view to the future in this respect. If what we do have is the revised 2 ISS staging. This is a system that differs a bit from previous systems. What are the practical implications for the future of this system?
Yes, and already we have a new system that has been proposed by the IMS International Myeloma Working Group, where we define patients are standard risk or high risk. We need today to have either deletion of 17p deletion by FISH, or a TP53 mutation, or as far as the translocation are concerned, we need to have a translocation combined with abnormalities of chromosome 1, either 1p or 1q, and beta-2 microglobulin remains important only in patients who have normal renal function. So with this new system, now we are able to identify a diagnosis approximately 20% of patients who are considered to be high risk.
So this is let's say, a genetic test. In fact, you have to do next generation sequencing for example, the TP53 mutations. What is your recommendation to clinicians to do the NGS, the sequencing for all patients, or is it too early?
I believe that we should start applying methodologies that are common in other diseases, such as chronic lymphocytic leukemia, and by using NGS, we can replace FISH, so we can detect not only P53 mutations, but also all the other abnormalities that we want to document so that we can stratify our patients. And also there are emerging data, both in symptomatic myeloma and in smoldering myeloma, that there are certain gene abnormalities that can offer additional prognostic information. So I think we're moving towards next-generation sequencing being the standard to evaluate the genetic abnormalities that we already know have an influence in our myeloma patients.
Yeah, especially also with the new immune therapies.
Absolutely.
Yeah. So with 14 novel regimens now recently approved for multiple myeloma, how did the guideline panel approach to integrating these new therapies with established standards of care?
As you understand, it was a very difficult process because with 14 new regimens, and especially some drugs that have been licensed at almost the same time for the specific indication, for example, patients at late relapses of myeloma, we had 4 bispecifics, 3 of them targeting BCMA that were licensed almost within a year, like teclistamab, linvoseltamab, or elranatamab, and talquetamab also targeting GPRC5D. You can imagine that we have to give some guidance for treating physicians, so how to use them, and what is the best regimen to use first, etc. So what we did is try to have a subgroup of patients, for example, in the late relapsing setting that I described, patients who are 3-class refractory or patients who are even 4-class refractory now that the BCMA targeting therapies have been second-line or third-line approved therapies, or even in patients that have received CAR-T first. So we have managed to have groups of patients in order to make it more easy for the treating physicians to follow these guidelines.
Yeah, I think that's especially important because it's very complicated, I think, for doctors that are not experts in multiple myeloma, and they have to know what they can tell the patients in terms of available treatments, etc. So we come back to that later. For now, what are the key recommendations for first-line therapy in newly diagnosed patients, and how do you tailor treatment for the transplant-eligible group of patients versus the transplant-ineligible?
Yeah. Myeloma is probably the only disease where we still, at the time of diagnosis of symptomatic patients, we want to know whether the patient is or may be candidate for high-dose therapy, and we tailor our treatment according to this. In the frontline setting, the paradigm of is the Perseus trial, which you, Professor Sonneveld, were the leading author. So for all transplant-eligible patients, we recommend essentially a quadruple that contains lenalidomide, bortezomib, dexamethasone with daratumumab or with isatuximab. And then patients, after a certain number of induction treatments, they undergo stem cell collection. They receive high-dose therapy with a standard dose of melphalan at 200 per meter square, supported by the stem cells. Subsequently, they receive additional courses of the quadruple as a consolidation, the total not to exceed 6 courses. So there are some patients that get 4 plus 2, or depending on the response and the logistics, they could get 5 plus 1, or even all the treatment upfront. And then patients are being considered for maintenance therapy with a combination of anti-CD38 daratumumab in your study, isatuximab in the German study, along with lenalidomide. The duration of the anti-CD38 monoclonal antibody could be guided according to the MRD status, and this is an evolving field even for lenalidomide, so there are some data to indicate that if you have a sustained MRD negativity along with negative normal imaging modalities, there may be a possibility to stop maintenance therapy. And we know that most of the benefit from lenalidomide therapy in patients who have received lenalidomide anywhere between 3 to 5 years. So this is a treatment strategy for transplant-eligible patients. In patients who are not considered transplant-eligible because of age, comorbidities, frailty, again, if they are older but fit, a quadruple is recommended. Again, we have 2 important studies, the IMBRO study and the CEPHEUS study. In both studies, lenalidomide, bortezomib, and dexamethasone are being used. In one study, daratumumab, in the other study, isatuximab. And then after certain months of therapy, patients continue on maintenance with anti-CD38 and with lenalidomide. The duration of maintenance, again, remains to be determined pending future studies and data that will accumulate. However, we have unfit patients who may not be candidates for this quadruple. We still have the combination of daratumumab with lenalidomide and dexamethasone, especially with lower doses of dexamethasone. And also there are emerging data that we have incorporated in the guidelines regarding combinations of lenalidomide with anti-CD38, for example, with daratumumab, a steroid-sparing regimen for unfit patients.
Going back to the prognostic factors, especially patients that we discussed with unfavorable cytogenetic abnormalities. This is a subgroup of approximately 20% maybe of the patients. Are they treated the same way in frontline setting as the so-called standard risk patients?
Yeah. In the current recommendations, we did not have enough evidence to recommend a different approach. So we have very interesting data from the Perseus trial, as you know, that to a significant extent the outcome of these patients has been improved. There are ongoing studies who are evaluating more intensive approaches. However, in the current status, we recommend a similar treatment, however, a more continuous therapy versus a standard maintenance treatment. But in the future, this will change, of course.
Yeah. And Professor Terpos, what about relapsed and refractory multiple myeloma patients? What are the most significant changes in the therapeutic strategy now, as highlighted in the guideline?
I think that this is a part of myeloma treatment that has the most exciting news, especially about immunotherapy. We have at second line approval of CAR T cells like cilta-cel. We have a third line, another CAR T product, ide-cel. We have the approval of belantamab mafodotin, which is an ADC targeting BCMA in combination with either pomalidomide and dexamethasone or bortezomib and dexamethasone in all 3 prior lines of therapy. And all this creates, as you can imagine, a very difficult topic for our colleagues who treat myeloma, but also for the general hematologists who treat myeloma, because probably they don't know what to use first, and this is the role of these guidelines to help them. And I think one important issue for the second line is if the patient had been exposed to daratumumab upfront or an anti-CD38, and the patient is refractory to that, and then the refractoriness to lenalidomide. So, for example, if a patient has not been exposed to daratumumab but is refractory to lenalidomide, then outside of the cilta-cel, who is approved for refractory to lenalidomide patients, but also the combination of belantamab with pomalidomide and dexamethasone that included 80% of patients who were refractory to lenalidomide. If the patient was not exposed to an anti-CD38, then the classical regimens like daratumumab with carfilzomib and dexamethasone or isatuximab with carfilzomib and dexamethasone are the preferred regimens. Another example is for patients who receive daratumumab upfront, and they are refractory to both daratumumab and lenalidomide. This is a difficult to treat population, and in our guidelines we suggest that the preferred regimens there are the cilta-cel, if it is available for the patients, or belantamab mafodotin in combination with pomalidomide and dexamethasone due to another 25% of the patients in daratumumab refractory in the main DREAM-8 study. For those patients who are at late relapses, at third line of treatment after the second relapse, then we have the 4 BiTEs that I previously mentioned, the 4 bispecific antibodies, 3 targeting BCMA, teclistamab, elranatamab, and linvoseltamab, and 1 targeting GPRC5D, talquetamab, along, of course, with cilta-cel or ide-cel. This was their first approval in the late relapsing setting, and also belantamab mafodotin that can be given in the combinations that I previously mentioned in a patient that has received 2 prior lines of therapy, for example.
So if I may interrupt you briefly, because it's getting very complicated.
It is, yeah.
And it's clearly described in the guidelines, in the manuscript, I think. But if I may summarize part of this, it's very clear that the next choice at relapse or progression is based on, let's say, the experience with the first-line therapy. If patients are very sensitive or refractory, how long? And based on that base, the physicians may find let's say, a choice for the next treatment, and also for maybe the third-line treatment. That's one of the big steps forward, in my opinion, that we give really a guideline to the treating physician how to make the correct choice. And this is also especially true with, let's say, the availability now of so many new agents, but also many new targets. And this is especially true for the immune therapies. And Professor Dimopoulos, what are the main considerations for the use of T-cell engagers, focusing on that group of novel agents?
Well, the T-cell engagers, they have revolutionized the treatment of myeloma. We have an excellent target, BCMA, which is expressed universally on myeloma cells, very little expression outside the myeloma cells, and we have already 3 approved bispecific monoclonal antibodies that have an unprecedented response rate exceeding 80% in many studies, with long progression-free survival, almost 1.5 years in very advanced phases of the disease. The new therapies, I mean, these are approved for later in the course of the disease, so we have realistic and very effective regimens for third-line and fourth-line treatment. And, of course, there are combinations of these agents with other approved drugs that are investigating their activity early in the course of the disease. As far as CAR T cells are concerned, we know that they are very effective late in the course of the disease. We have long-term follow-up with cilta-cel in very advanced patients, and for the first time we can see a potential plateau, and we are starting talking about potential functional cure in multiple myeloma. And as Professor Terp mentioned, we have approved CAR T cells in the second and third line treatment of myeloma.
So very briefly, what is the optimal sequencing of these new targeting?
In the guidelines, we recommend CAR T cell where the patients can be treated with that, the first anti-BCMA treatment, followed by either antibody-drug conjugates and bispecifics, depending on the condition of the patient, how long has elapsed since the administration of CAR T cells, and of course, we want to make sure that there is BCMA expression on plasma cells before we engage to another anti-BCMA therapy. And of course, there is a difference between bispecifics and antibody-drug conjugates at belantam mafodotin. We know that belantam mafodotin does not need the functioning T cells to exert its function. So this is a difference that one may want to take into consideration when choosing the second anti-BCMA therapy.
So we are here at ASH in Orlando, 2025. Is there any news for the new immune therapies?
I think so, yeah. I mean, there is groundbreaking data with a combination of teclistamab with daratumumab. We had a glimpse of this great regimen that has an unprecedented hazard ratio of less than 0.2, with a very high response rate, very long progression-free survival. More than 80% of the patients are progression-free at 3 years, and I think this is a practice-changing regimen in the second line and the third line treatment of myeloma, and also other presentations of bispecifics with newer agents, for example, with cell mods, elranatamab with mezigdomide, even teclistamab with daratumumab as frontline treatment in elderly patients. So there is a lot of activity in the field of myeloma, and I believe that we should start thinking about updating the guidelines in the very near future.
Almost every year we need an update of the guidelines. And so this is about patients with multiple myeloma, but there's also a condition known as smoldering multiple myeloma, let's say a pre-phase of multiple myeloma. Those are also discussed in the guidelines. And Professor Terpos, can you comment? What are the recommendations for smoldering? Should they be treated or not? Is there study evidence for that?
I think the smoldering myeloma is becoming also challenging, especially the high-risk smoldering. So what we describe in the guidelines is that we use the 20-20 rule in order to stratify the patients to low, intermediate, and high risk, and also we can apply some of the cytogenetic abnormalities of high risk in order to have one more category, the ultra, let's say, high risk smoldering. For the low risk, I believe that it's enough to check the patient every 6 months to a year, because these patients are at very low risk of having progression within 2 years, and the intermediate risk is the same. For the high-risk patients, however, they have a probability of progression between 25 to 50% at the next 2 years. For these patients, there is a pivotal study that was led by Professor Dimopoulos, the Aquila study, that compared daratumumab with the active observation, and we've seen that daratumumab given for 2 years increased the PFS, but also seems to increase the overall survival of the patients. At the time that we wrote the guidelines, the drug has not been approved, but we took the risk to suggest that possibly these patients with high-risk myeloma have to be treated. Of course, we suggested that the treating physicians may use daratumumab for the treatment of this patient, and daratumumab was approved by FDA for this cohort of patients. On the other hand, we have to say that there are a lot of voices in the myeloma community suggesting that if you need to treat a patient, you have to treat him like true myeloma and not to give only one drug like daratumumab. Of course, we don't have evidence for that. We are waiting a lot of studies. But based on the evidence that we have, a treating physician with patients with high-risk smoldering myeloma, he could treat him with daratumumab for 2 years.
So, Professor Dimopoulos, you were the coordinator of this the Aquila trial. How does it translate in your daily practice now for the smoldering?
Yeah, as Professor Terpos mentioned, for the first time we have an approved agent to consider for a patient with high-risk multiple myeloma. So this is something that we can discuss with the patient to present the data, and then I also believe that if there is a joint decision between the treating physician and the patient that he will proceed to treatment, realistically, this strategy should be aligned with what we do with overt myeloma. For example, in a younger patient with high risk, when the decision is made to treat, I believe that he would be better served by using a Perseus type of approach, try to induce a deep response. But for older individuals, I believe that single-agent daratumumab may delay the development of symptomatic disease, which is also very appropriate. The important issue is that we have now a therapy that could be given to patients that do not have overt symptoms.
Talking about symptoms, that's another aspect of multiple myeloma, of course, the organ symptoms. And without going in much detail because of time, is there any change in the management of myeloma-related symptoms with the new developments on therapeutics?
We have described in details into the manuscript the different complications of multiple myeloma, like bone disease, infections, or renal impairment. But I want to say only a few words about some changes that there is in the field. For example, for patients who have renal impairment with bone disease, denosumab seems to be the best approach, while on the other hand, zoledronic acid remains the cornerstone of the treatment of myeloma bone disease. For infections, that is an emerging problem, especially with the anti-BCMA bispecific antibodies. It seems that we need to offer not only the standard antibiotic prophylaxis or antiviral prophylaxis that we use for multiple myeloma, but also to give intravenous or subcutaneous immunoglobulins, irrespective of the levels of IgG, in order to reduce the infection rates.
Yeah. No, I completely agree with you. I think one of the big changes, in my opinion, is the introduction of the IV immunoglobulins with the new immune treatments. They're really different from everything we did in the past in the myeloma patients. Another thing that changed is the input of the patients. The patients reported outcomes, quality of life. What role should these play in the decision-making of the treatment?
I think that we described very nicely, even in the newly diagnosed multiple myeloma management, as Professor Dimopoulos mentioned, that frailty is an important issue. Several patients who are elderly, they have comorbidities. This can make us have different decisions than the fit patients. For example, a quadruplet for a fit elderly patient, but a doublet with daratumumab plus lenalidomide, for example, in someone who has a lot of comorbidities or unfit or frail, with possibly 2 cycles only of dexamethasone and then only daratumumab plus lenalidomide. The patient-reported outcomes are extremely important even in the relapsed refractory setting, and with the use of the new immunotherapies, I think also important to find out who are the patients, for example, who are going to have ICANS or CRS or severe CRS, in order to prevent that. And as I mentioned previously, with infections, to give IV or sub-Q immunoglobulins in order to prevent the infections and improve the quality of life for our patients.
Well, these are exciting times for doctors and for patients, I think, because not only the treatments change, but also the symptoms, the adverse events that patients experience. The whole practice of hematologists for myeloma patients, I think, is changing, and this is an important aspect that should be addressed also in future guidelines. So, Professor Dimopoulos, from that, what are the main challenges that you can foresee in implementing all these guidelines across the different landscapes in Europe?
First of all, the more rapid approval by regulatory authorities of regimens that are truly groundbreaking. And then, of course, the reimbursement, especially in European countries. We know that there are countries where reimbursement is almost aligned with the approval. In other countries, there are delays. I believe that living in the European Union, we should have a more homogeneous treatment strategy and approach for our myeloma patients. I believe that the European Myeloma Network is contributing significantly towards that direction, but there is still room to try to implement the treatments proposed by the guidelines in everyday practice of hematologists, and also to educate hematologists about these new regimens. We know that there has been advances in all malignant hematologic disorders, so for practice hematologists sometimes it is hard to keep up with all these evolutions, and we have to try to make it as simple as possible so that the patients will benefit from these advances.
Thank you. So if we look ahead for the next 2 years or so, what evidence is still lacking that should be included in the next update of the guidelines? And what are the priorities, Dr. Terpos?
First of all, we are going to have a lot of evidence with all these amazing immunotherapies that are going to earlier lines of treatment. For example, the bispecific antibodies combination of teclistamab plus daratumab that goes earlier, 1 till 3 prior lines of therapy, so at second line. We have other bispecific antibodies with different combinations that may come earlier. And also cilta-cel or ide-cel are into clinical trials in first line even. So you can imagine that within the next years we are going to have a lot of data that will change these guidelines. However, we have a lot of other challenges. For example, the patients with high risk or ultra high risk myeloma, or with a high risk low definition of IMS that includes also the so-called ultra high risk with 2 or more abnormalities that we used in the past. So there are studies now that target this population, the high risk, and we are going to have data on this population, as well as patients with extramedullary disease. There are some new publications suggesting that possible combinations of bispecific antibodies targeting different antigens in the surface of myeloma cells, like teclistamab plus talquetamab, may be extremely efficacious for extramedullary disease, and also for plasma cell leukemia, which is another form of plasma cell neoplasm. But I think that all these new data that are coming will make us update the guidelines, I believe, not after 4 years like the previous one, but definitely after 1 or 2 years.
So, Professor Dimopoulos, not only the doctors are reading our guidelines, I think also the authorities and the regulatory agencies like EMA. And should we, in the next version of the guidelines, also address issues that are important for the regulatory agencies for approval and maybe to work with them on how we can implement the guidelines into real clinical practice?
Yes, already there has been an improvement with FDA by accepting minimal residual disease negativity as an endpoint. This has yet to be implemented by EMA. I believe this is important for the future development of clinical trials and also for the more rapid readout of clinical trials. And of course, other possible biomarkers, as we mentioned, circulating plasma cells that could be used as an endpoint for response. They may be complementary with MRD negativity, so this is something else that we may want to incorporate, or even circulating plasma cells in the smoldering myeloma patients as a dynamic system that could, identify early patients that are progressing to symptomatic disease. I agree with you that interaction with regulatory authorities, especially EMA, is important. And in Europe, we have the European Myeloma Network that can play this role in a very significant way.
Yeah, as you described before, the guidelines offer a roadmap on how to transition from a one-size-fits-all type of approach to a dynamic, patient-centered and tailored treatment strategy.
Right, I agree with you. This would be the ideal way to go so that we can have a more individualized approach for particular subsets of patients in a particular phase of their disease.
Dr. Terpos?
I believe that the idea to having new guidelines, the opinion of the authorities is extremely important in order to guide us also how we can implement the new treatment for the majority of the countries. I believe that we tried in these guidelines, and I think we will improve that in the next ones to talk about the patient-reported outcomes and make an individualized approach as more data are coming in specific subsets of patients. I think that the updates of the guidelines will not only evidence plus guideline, but also we are doing our best to individualize treatment as much as possible according to the data that we have.
Thank you. It has been a pleasure to present these guidelines with both of you. I also would like to thank the audience for listening. And if you want more details, please look at the manuscript in the literature. There you can see the full text of the guidelines. Thank you.
Thank you, Professor.
Thank you so much. Thank you.